Today on the Discourse, a growing global row over access to a breakthrough HIV prevention drug. Médecins Sans Frontières says that efforts to secure Lenacapavir for use in its programs have been blocked, despite the medicine being held as a game changer in the fight against HIV. The organization argues that limited supply and restrictive licensing are keeping life-saving treatment out of the reach of some of the world's most vulnerable communities. At the same time, South Africa is preparing for a phased rollout of the injectable, which can provide protection against HIV for up to 6 months at a time, raising fresh questions about equity, pricing, and global access to medical innovation. So, who gets access first and who is left behind? Well, joining us for this discussion are Dr. Tom Ellman, Director for Médecins Sans Frontières, Doctors Without Borders Southern Africa Medical Unit, and Fatima Hassan, who's founder and director of the Health Justice Initiative in South Africa. To both of you, thank you very, very much indeed for joining us, and a very warm welcome.
Morning. Thanks for having me.
Morning. Great to be on the show.
So let me start with you, Dr. Ellman. How would you describe MSF's engagement with Lenacapavir so far? I mean, what role do you see it playing in your work?
Well, it is, as you said, a game changer. It's an absolutely essential part of our prevention options for people who are vulnerable to HIV in many countries, and we desperately need it. It's not overstating to say this has the potential to help us end AIDS, and Gilead is deliberately preventing us from having the access that the populations we support need, and that's in many countries. So we are working all over the world. We're a large humanitarian medical organization working with the most vulnerable people at risk of sexual violence in Congo, sex workers, men who have sex with men, transgender, drugs users across Latin America, Central America, Africa, and Asia. And we need this drug everywhere for people who are at risk. And Gilead is absolutely dragging its feet and preventing us from accessing the drug. Despite multiple requests to buy the drug from them, they have refused us, repeatedly stating, as we know very well, that they want to do it through the Global Fund. They want us to wait for generics. And we know from our experience, which working with the Global Fund, trying to access it, that there is not enough to go around, and that the supply that they are currently giving is not available and will not be available to many of the populations who so desperately need it.
All right, we'll explore that a little bit more shortly. But in the meantime, Fatima, from your perspective, how should we be thinking about access to new HIV prevention medicines like this at a global level?
Thanks, Peter. So first, I just want to preface my remarks by saying that Gilead's refusal to sell Lenacapavir to MSF is scandalous. And I think that's part of the bigger systemic issue of what I would call the geopolitics of exclusion. So unfortunately, we have a situation now with one of the most important HIV prevention tools that has been researched and developed also through the participation of the Global South, our researchers and our trial participants, where it's a geopolitics of exclusion, where Gilead makes all the decisions and has all the power. So the net result is, before we can even think of an equitable approach to rolling out a number of key HIV prevention tools, including Lenacapavir, we have a problem of scarcity, which is self-created by Gilead. And I would really argue that the scarcity has been created with the collusion and support of the US government, and to an extent the Global Fund as well. And then we also have a problem of secrecy. And Peter, we've talked about this before, how I feel about secrecy on pricing around corporate pharmaceutical power. But that's a situation we've landed up in now. We've got scarcity, which is self-created. We've got a drip feed of supplies of Lenacapavir coming into a handful of African countries, including South Africa. We've got price secrecy. And we've got the geopolitics of inclusion, where access is now being determined by the Trump administration to a large extent. And so trying to approach access from an equitable lens is becoming almost impossible because we're dealing with these three different factors simultaneously.
Dr. Ellman, it sounds as if this is not uncommon, this behavior by Gilead. And if it's true, why have they been allowed to get away with this? Is there nothing that can be done?
Well, that's a very good question. The rules are stacked against equity in many ways. We've had many fights with Gilead over the years. In the 2000s, they tried to limit access to tenofovir. A bit later, they came up with a groundbreaking sofosbuvir, a drug for hepatitis C, where similarly, us and other activists had to fight tooth and nail to get access, and again, to reduce this drug from the scandalous prices that Gilead charges in order to maintain its profits, down to a realistic price. And Lenacapavir is a classic example of this, which is currently sold for almost $30,000 per year in high-income countries. So no wonder Gilead wants to protect as much as possible that market, when we know well that this drug could cost less than $40. You know, this is somewhere we've been before with antiretrovirals, and to continue to have these same battles tells us how deeply the system is flawed. On top of that, Gilead is able to present this drip feed, this illusion of scarcity, as something it is trying to combat rather than something it has deliberately created, is, as Fatima said, scandalous.
Fatima, we've heard and seen about miracle drugs before. Sometimes I think might be, overstating it. But what makes this one different, do you think? Is it really a massive game changer?
So, the scientists and the researchers argue yes, and we obviously follow the evidence. The efficacy rate in trying to prevent HIV is considered to be 95% or even up to 98%. So it is a significant game changer. It's a twice-a-year injection, which also then makes it easier to administer to millions of people around the world. But if we put this in context, the ease in which you can use an injection in resource-poor countries, you've got 1.3 million new HIV infections in the world, according to UNAIDS, annually. That is what we're trying to address. So when we talk about scarcity, what we mean is this new announcement by Gilead and the Global Fund that they'll provide 3 million doses of injections for the whole world. That puts things in perspective. You're trying to address a massive problem of HIV infections. You're trying to prevent it, particularly the injection works really well in adolescent girls, in pregnant women, in men who have sex with men, in sex worker populations, particularly for vulnerable groups. So finally, you have a tool. Peter, this is what we've all been waiting for and working for the last sort of 3 decades, to try and stem the tide of new HIV infections. And if you want to end AIDS, and if you want to prevent new infections at the scale in which it's currently taking place in Africa, in Latin America, in Asia, then simply providing 3 million doses for the whole world is not sufficient. I mean, to put this in perspective, South Africa is considered to be at the epicenter of the HIV/AIDS epidemic. It's now 2026. We've been promised these doses for some time. Finally, 38,000 doses came. I mean, we need 2 million injections right now. So, we can't emphasize and stress why this is such an important injection, why it's such an important intervention, why it's such an important prevention tool, because you could actually stem the tide on HIV infections. And, to go back to your earlier question, well, are we powerless? Why can't we take on Gilead's greed? Why can't we challenge them on their broken promises? We've been in this position before. And we can only do so much as civil society and humanitarian organizations. We can fight a bit for price transparency. We can fight a bit for accountability. We can monitor dosages like we did in the COVID pandemic. But ultimately, it's up to African governments, including the South African government, to take compulsory action against Gilead. And it's refusing to do so. It's accepting a status quo of 38,000 doses. It's accepting a status quo of where there's only a handful of generic licensees that will, maybe in the next 2 years, maybe in the next 3 years, we're not sure what the timelines are, will be able to supply generics. Only now they've announced an expression of interest process for South African generic manufacturer. So I think the public relations exercise that Gilead is undertaking, which Tom alludes to, oh, we're providing 3 million doses, oh, we're doing this for the Global Fund, oh, we have generic licensees. The reality on the ground is there aren't enough doses, and nothing is being done to prioritize, I think, compulsory action against Gilead. And we can talk shortly about the geopolitics and the role of the US government and its very sinister influence over this entire global rollout. But let me leave it there for now.
Yeah, I'm sighing because it's just so sad to hear, because in the end, Dr. Ellman, who is the most vulnerable as a result of these kinds of blockages?
Well, so Fatima just went through some of the most vulnerable groups. Often it is those who are most excluded and stigmatized within society in settings that have already got major disruption to their health systems through war, through conflict, people who have had to migrate, refugees, and then on top of that, the woman who becomes pregnant, who is at risk of catching HIV, and members of the key populations in particular. And it's notable how little reference is given to these most vulnerable groups: sex workers, men who have sex with men, drug users, trans communities, in the rhetoric that comes out of the US government, who rightly point out how important it is that pregnant and breastfeeding women have access. But let's not fool ourselves. When they talk about this, their focus is on preventing transmission to children, also hugely important. But where is the focus on the individual, the focus on women and men who are most at risk? So there is a rejection of some of the science that tells us who is most at risk in favor of a narrative that suits a government, particularly a government that criminalizes many of these populations. So we need access in places like Eswatini, where we are working with the Global Fund, and we were given just 70 doses in Eswatini, in fact, the country with the highest incidence of HIV globally. Those doses were used up in just 4 weeks. In Kenya, we've been given, I think, 30-something doses. So we're trying to work with the Global Fund. They don't have enough. Other countries like Central African Republic, Democratic Republic of Congo, Ethiopia, we are looking to get access in these countries. In Central African Republic, we have been working with the Ministry of Health and the Minister of Health to try to get access. None of those countries are included currently in the rollout plans of the Global Fund. And then when Fatima mentions 3 million for the whole world, that's right. It's far from sufficient, but it also is not the whole world. So many countries in Latin America, many countries, as Fatima mentioned, whose populations participated in the research studies that led to this groundbreaking medication being approved, they're excluded, explicitly excluded from any reception of the drugs through the Global Fund, any reception of the generics that Gilead is promoting as the solution in the longer term. And those populations have many people as well. Over 20% of all new HIV cases globally occur in countries that are not going to get any access through Gilead's current promotion of working with the Global Fund, or through the generics that hopefully will come next year. We still have no guarantees. So,
Fatima, tell me a little bit more about these global systems that shape who gets access first to medicines like this?
So I mean, Fatima's better placed to answer some of that than me, but the
No,
world is
I
broadly
actually asked
divided.
Fatima.
Sorry. Go ahead, Fatima.
My apology, but I mean, I'm sure I know what Tom is going to say. The first thing that we've always argued as health activists is that there's a systemic bias against people in the global south. So the first problem, as we saw in COVID, as we saw in the HIV/AIDS epidemic, is that pharmaceutical companies and CEOs of these pharmaceutical companies make these decisions about who's prioritized for access versus what the public health need is. So if we had a true public health-based, evidence-based rollout for Lenacapavir, this is not how it would be implemented, because currently the need is for 20 million people to get access to Lenacapavir all around the world, including in places where there's worrying trends of higher rates of HIV infection. The current number that's been promised actually hasn't been delivered of the and I have spoken about is not even close to 20% of what the real public health need is. So I think it's just an illustration of the continuation of the abuse of power by pharmaceutical companies like Gilead. Tom has given you previous examples. We know the examples of HIV and COVID. But let me just point to 3 issues with the way in which Gilead is running this global rollout. And, it makes you wonder, and I think you're asking the right question, why is this allowed to happen? Why can't no government in Africa or Latin America or Asia or in South America take action against Gilead? Because it's allowed to take action under international trade rules. It's just unable to at the moment because of the pressure of the US government. There's 3 ways in which Gilead is excluding people. The one is the limited doses for the entire world. We've spoken about that. The second is even when it's making it available in certain countries like South Africa, it's not making it available for the private health sector. So you and I can't go to the chemist right now and get a Lenacapavir injection, even though we would be able to pay for it. That's not being allowed because there's an exclusion in the way in which the licensing and the agreement with the Global Fund works. And then the third exclusion is just excluding a whole lot of geographies. We don't know why, because Gilead has decided that's their commercial marketing strategy. So unfortunately, it's as we've argued in many other epidemics and many other instances before, that access is being determined by forces outside of public health, outside of evidence, and it's usually, and in this case, we believe it is being determined by a commercial strategy of profit. I think what's different with this particular case of Gilead is that there's a 4th element, and that is the US influence. And if we can just talk about that for a second, the way in which the rollout is being carefully orchestrated with the support of the US government and the announcements that they made towards the end of last year of which African countries will qualify for first doses or first batches of supplies from the Global Fund shows an element of an agreement between the Global Fund, the US government, and Gilead, where, for example, the US government said South Africa would not be eligible from PEPFAR-funded supplies because they don't like our politics. I mean, the white genocide and our ICJ case. So some countries are being prioritized for access based on, are they willing to give their mineral rights up to the US government? Are they willing to host US military bases in their countries? And that's why some of those countries were prioritized for access towards World AIDS Day last year, December. And some countries are not. So it's this really bizarre, incredulous, and I think, in my view, criminal situation where Gilead's rollout strategy is being determined by the US government's political interests because Gilead is a US-based company.
Right, and in 30 seconds each, final thoughts. What should we be thinking about? What can we do? Let me start with you, Dr. Ellman.
Yeah, I mean, our request is really simple. We just want Gilead to sell us their drug. And they have refused even to negotiate, even to talk about pricing. We're not asking for it for free. We know they have to make a profit, but they won't even talk to us. And that for me is very clearly evidence that they are putting Gilead first, not people first.
And Fatima?
We need millions and millions of doses. It's time for African governments to step up and take compulsory action against Gilead and not be bullied by the US government and Gilead with the support of the Global Fund.
To both of you, thank you very, very much indeed for really illuminating this massive problem. And let's hope that, as you say, our governments, the international communities generally can deal with some of these pharmaceuticals. Thank you so much indeed.
Thanks very much.
So that was Dr. Tom Ellman, Director of Médecins Sans Frontières, Southern Africa Medical Unit, and Fatima Hassan, Founder and Director of the Health Justice Initiative in South Africa, speaking to us on the discourse about the access to Lenacapavir and the broader questions of equity, pricing, and global health justice.